Good afternoon. Welcome to Medical Grand Rounds. I'm Bob Wachter, Chair of the Department of Medicine at UCSF. I think folks by now know the usual ground rules for our virtual Grand Rounds. There'll be closed captioning. The video will be on YouTube in a day or two. If you are interested in seeing me, credits stay on at the end, and there will be information to take you to the right site to go ahead and register for it. Our title today is A Health Equity Tapestry, Weaving Research on Health, Structural Violence, Stigma, and Our Lived Experiences. And I'm really excited to have our speaker, who is fairly new to the UCSF family, although returns after a prior engagement. This is Jesus Ramirez Velez, who is the professor and chief of the Division of Prevention Sciences. We recruited Jesus to UCSF last year, and we're thrilled to have him here. His work is deeply rooted in the social and behavioral sciences and focuses largely on health equity and community engagement. He's had an incredibly diverse research career with traditional publications and grants, including from the NIH and several foundations, as well as producing a documentary, Tal Como Somos, which means Just As We Are, chronicling the lives of Latino gay men, transgender persons, and people living with HIV/AIDS. It's been featured widely, and including its several international film festivals. His career has really focused on the experiences of communities, particularly excluded communities, and their health, and what kind of behavioral interventions can improve their health and health outcomes. Prior to coming to UCSF, he served as director of the Health Equity Institute at San Francisco State. Before that, he chaired the Department of Community Health Sciences at the University of Illinois Chicago School of Public Health. But as I said, he is returning to UCSF in 1998 to 2001. He was a visiting professor at our Center for AIDS Prevention Studies, which now is part of the division that he now leads. So that's always an exciting story when someone grew up here, went out and did all sorts of great stuff, and came back. So thrilled to have you back, Jesus, and look forward to hearing your talk today.
Good afternoon. Good morning. Thank you, Bob. I appreciate those kind words, and thank you everybody for being here. I particularly appreciate the interest that you have on this topic and believing that I have something important to share with all of you. So with that, let me start sharing my screen. As Bob noted, the title of my presentation is A Health Equity Tapestry, Weaving Research on Health, Structural Violence, Stigma, and Our Lived Experiences. The purpose of the talk is not to go in detail, particular any of these concepts. We can spend days and seminars talking about stigma, our structural violence, and of course, how they connected to health equity. Rather, what I want to do is to present a rather broad research agenda targeting or trying to move us towards health equity, using some of my research projects as examples. With a caveat that I don't think of myself as an expert, I think of myself as a student. So this is the topics that I'm studying. This is the topics that I'm interested in. And if you have any questions or concerns or clarification, please do not hesitate to share and so contact me directly. So first, I want to thank a large group of people that my career and the projects that I will be outlining here have supported my research enterprise. Various institutes of the National Institutes of Health, the Rockefeller Foundation. I've been so lucky that they allow me to finish 2 of my books right there in the Rockefeller Foundation, the Bellagio Center. My colleague, Matthew Morocco, a photographer and an artist who has allowed me to use his art for many years, and most of the photography that you will be seeing to the presentation comes from him. And of course, I will not be here with my wonderful collaborators and research teams here at UCSF, the Division of Prevention Science, San Francisco State University, the University of Illinois Chicago, and of course, Northwestern University. And I apologize if I'm missing any of my wonderful colleagues. Thank you. All right, so what are the threads that I will be working with? These are the threads that I will be weaving to trying to present an idea of health equity. One is structural violence and stigma as I have applied to health research, particularly with communities of color and gender and sexual minorities. You will see several examples of how I have used structural violence and stigma and how I'm trying to learn about them as we work with gay men and HIV and AIDS and substance abuse. And then I'll move towards the connection of researcher and researched. That is the interdependence, or what some scholars call the positionality, and how my position as a researcher has influenced what I study, and the people and the subjects that I study have shaped my career. And the third, how our anti-racism efforts in science and health research can be informed by that particular issue of interdependence and positionality as we do research on structural violence and stigma. Let me start with my positionality and take you back to the late 1980s, early 1990s. I finished college. I started working in the border, Juarez and El Paso. And at the same time, I was coming out as a gay man. And as many as you know, what we had in front of us, it was a horrendous epidemic. HIV and AIDS were devastating our communities. My newfound community was being devastated by this epidemic. So I immediately came out as a gay man and getting involved. We created a community organization, a community group of people in both El Paso and Juarez to try to help our friends, lovers, partners who were dying and suffering. So that's what I was confronted at the age of 23, 24 years old. On the other side, we had in both sides of the country, on both sides of the border, and even around the world, public health institutions that were at least, the very least, negating the existence of the condition, denying it, and at worst, further stigmatizing us and further marginalizing us. So there were two important things happening here. On the one side, we had these community organizations because HIV compelled me to become a community organizer and eventually a researcher. But this larger AIDS movement was able to do three wonderful things. One was with our limited resources, we tried to, of course, bury those who were dying, taking care of those who were suffering, and doing as much prevention as we could. We did our own research to develop messages that were not denying our sexuality and our humanity, but rather that they were based on our lived experiences and they were not blaming us. So we created strategies that we call right now harm reduction or risk management. At the same time, we were doing our own research to understand how we can move forward the research around HIV and AIDS, both at basic research and public health research. And groups like the ACT UP, the AIDS Coalition to Unleash Power, it was very successful in moving this forward. They did pressure the FDA, the NIH, and the CDC to do two things. Number one, to change the way they were doing research. They developed more efficient protocols to expedite the research process, number one. And second, to be inclusive. The inclusion that we have in our research of women and people of color is largely due to these efforts. They push and they lobby and they succeed in bringing people of color, the people that were affected by the pandemic, gender and sexual minorities, into the table to discuss strategies. On the other hand, what do we have? We have these institutions that were blaming us and stigmatizing us. And what I learned here in this period of my life, in the words of my dear friend Steve Epstein, whose book I'm being showing on the smaller circle, is that science is impure. Public health is impure. Health research is impure. What does it mean? Impure means that the research and the public health strategies that we do are embedded in politics and in culture, as we recently learned with Mpox and with COVID. And we also learned that we needed to be working close together with communities affected by pandemics. These are the lenses by which I became a researcher. This is the lenses that I developed to see health research. And this is the lenses that I currently use to investigate HIV and the gender, sexual minorities, and people of color with this broader agenda of health equity. I want to anchor this broader discussion with my most recent project. I would just say our research project, because it's a research team on older gay men. The title of this project is Structural Violence, Aging, and Health. And we actually at the beginning just to start collecting data in the next couple of months. In this diagram, what you see is typical, what we can typically consider in health research, stress and social support processes, in which we have health outcomes on the one side being affected by distal processes that cause stress, such as layered stigma, structural violence, and the resources that buffer those negative effects, and then biomarkers. What you see in these photographs is exemplifying the men that we're working with. We're working with older gay men over the age of 55. We use 55 because it's the marker that the CDC uses for definition of older person living with HIV. We're comparing, contrasting people that are living with HIV versus those who are not living with HIV across 4 ethnic groups here in the Bay Area: African American, Asian American, Latinx, and white men. We want to see how they're aging and how this structural violence, particularly in layered stigma, affects them across ethnic groups and across HIV status. I will be using these slides in this process towards a presentation, and I will walk into each of these concepts as we move forward. Before I move forward with the process, let me sort of take a step back and talk about why it's so important beyond HIV that we study older gay men. And I will argue older LGBTQ communities here in the United States. We're in the midst of a wonderful social demographic phenomenon. The baby boomers became older age. The baby boomers is the largest generation in the United States, just surpassed right now, a couple of years ago, by the millennial generation. But the current cohort of older populations is vastly baby boomers. In this graph, I highlighted 2 lines of generations, if you will. On the bottom, we have the traditional United States generations from the 1900s forward, and then on the top, I highlighted the LGBT generational cohorts from the 1900s to compare and contrast. So here, of course, we have the baby boomers, 1946 to 1964, which constitutes the larger group of older gay men. Because with the baby boomer, what we are witnessing is not only a large cohort of folks with very particular experiences aging, but we also have, for the first time, the aging of a group of people, a collective that call themselves lesbian, gay, bisexual, and transgender people. Same-sex desire, different gender expressions have always existed in our societies. But this is the first time that a group of people that created a movement called LGBTQ are aging together. They're getting old and they're changing society. With them, we have a large group of people living with HIV and being affected by HIV. So we're also witnessing people living with HIV at an older age. The second group in the older population is Generation X, those between 1965 and 1980, that would be me. And then the third group, the older group, is the silent generation, 1928 to 1945. On the top, what we have is the first cohort, the silent generation, is the group that experienced homosexuality or same-sex desire as a criminal activity or an illness. That in the 1950s and 1970s became a coming out process. Coming out at the time, it meant that someone would adopt an identity of lesbian or gay. Then that was followed by the sexual revolution that created the gay liberation movement in the 1960s and 1970s. And that's when we see the creation of the lesbian, gay, bisexual, and transgender collective identity. And then we have our a tremendous tragedy, the AIDS cohort, 1981 to 1990s. And then currently what we have is what we call the queer, I will not say cyber queer, I will say digital queer and marriage equality. Across the graph, what you see is key events that have shaped the life of a typical quote unquote baby boomer, marked by those age in brackets that I have put 15, 25, 35, 45, to illustrate where were they when these events happened and how they were changing their lives. We have first the Civil Rights Act, of course, when they were young, and then followed by the Stonewall, which marked the gay liberation movement here in the United States. And then we have, under the AIDS epidemic, the antiretroviral therapies. And they were in the gay B, what I call gay B boomers. They were late 20s and early 30s. It is important to mark here this age cohort, because by being in that age bracket, the gay B boomers were the most affected by the AIDS epidemic. They have the highest prevalence of HIV, the highest mortality of AIDS, and they suffer the greatest loss of partners, social networks, friends, and social supports than any other group in that particular period. And then we have the more recent marriage equality movement. If you will, many of them pass, quote unquote, our societal markers for being able to marry. They're benefiting a little bit, but the most beneficiaries of that marriage equality, it will be the Generation X and then moving forward. I want you to take two things away from this graph. Not only that there are important differences between being a heterosexual person, being an older person versus being a queer or LGBTQ person. Also, that studying the life course perspective is so important. We cannot study how people got to the age of 60 or 70 without realizing what events and what culture changed the way they see aging and their own health. And then the third piece is a big part missing in this graph, is the life of Black and Latinx, Asian American, LGBTQ folks. This graph that I presenting here comes primarily from the experiences of white folks. And what I'm presenting next is some experiences that tells us that queer of color, where maybe they deserve a separate line here that we can overlap and contrast their generational cohorts. So what are the main differences between the current older gay B boomers and the overall larger baby boomer generation? Or if you will, what is the difference between the current older gay men vis-a-vis their heterosexual peers? So one of them is, of course, they're single, they're childless, and they're living alone. That's already very different from the previous generation and their current peers. And then a third one, they have small and fragile social networks. As I noted before, many of them lost a big chunk of the social networks and social support. At the same time, we have to remember that LGBTQ communities have been resilient in terms of building their own networks, building their own communities when they have been compelled or expelled out of their own communities. They create very strong communities, but those communities, relatively speaking, are still small and very fragile. And then part of that reason for being small and fragile is because of the stigmatization that they have encountered. But notably now, older gay men are facing another stigmatization, older age, and within their own communities. This stigma towards older age within our communities is further is amplified, if you will, because of our current digital communities. We meet other folks via apps or via Zooms or via or virtually. And that emphasizes our looks and our youth. And so that puts older gay men at disadvantage of being able to connect with other communities. Then we have, of course, the HIV/AIDS epidemic, that not only they went through it and they were affected either because they were infected by HIV, they suffer AIDS, but because they lived through that process. And now many of them are aging with HIV, and we need to understand what is the impact of that physiological and psychosocial experience at older age. And then last, we have what I believe is a key question in our field. Are we witnessing accelerated or extraordinary aging? Accelerated aging means that the signs of biological if you will, or even psychological aging comes earlier in life for these men. Or extraordinary aging, that is that precisely because of the life course and where they have been, they have the tools to cope with the challenges of aging. They're better able to cope compared to a larger population with the challenges that aging poses to all of us. In the next slides, I will try to illustrate some of the questions that we are raising around accelerated extraordinary aging. We don't have the answers, and we will not have, and I think we as a larger field for quite some time, but part of the research that we're doing is to get at this particular point. Like I said before, the importance of studying older gay men and the larger older LGBTQ population goes beyond that. Why? Because as this article, recent article in the New York Times highlights, as Generation X and Boomers age, they confront living alone. More older Americans are living by themselves than ever before. That chief presents issues on housing, healthcare, and personal finances. I don't need to say more, except that this is a wonderful, interesting social phenomenon. We're witnessing a convergence, if you will, in many elements between the lives of LGBTQ folks and heterosexual folks. We are sharing similar experiences. So if we study how older gay men and older LGBTQ communities are aging, we will be learning about the aging process of the larger population and how we overall need to make changes about housing, healthcare, and personal finances that take into account both experiences. So that's the background and the significance to which we arrive, or my team and I arrive, to this particular model, in which we pose particular hypotheses and questions about how stigma, structural violence, and resources come into biomarkers at the clinical level and how they affect the health outcomes. The hypothesis that we're testing here, we're collecting actually data for, I forgot, but I think it's we're about 600 folks here in the Bay Area to test this specific hypothesis. And this hypothesis that we pose here came from this book that I published a few years ago. The title is Queer Aging, the Gay Boomers and a New Frontier for Gerontology, published by Oxford in 2016. And here, this work was ethnographic work that I did in Chicago, primarily the Chicago metropolitan area. But ethnographic work means I did in-depth interviews and participant observations with older gay men from 3 ethnic groups: Latinx, African American, and white men. Half of the sample that I studied were HIV positive and the other one HIV negative, because I wanted to compare and contrast their experiences. In this book, this is my main argument, that older gay men, gay boomers, struggle to reconcile the clashes between their own sense of self and the social and cultural demands of their prevailing gay and heteronormative gerontology worlds. That means they're trapped again. And they again encounter the task of making sense of themselves and their social connections in a context ruled by norms that do not suit them. So what I find is that many older gay men are really struggling to live as an older people. Yet at the same time, some of them are building and creating new ways of connecting with others and creating their own communities. All right, so let me come back to the specific model and let me walk you through some of the concepts to make sure that you can understand how do I see and what do I mean by structural violence, layered stigma, and so forth and so on, and how they affect health. First is structural violence. What does structural violence means and how it's connected to health equity? Structural violence as a concept was first used by Norwegian sociologist Johan Ganlock, I think Loth is his last name. He was studying peace and violence. And the concept was later taken by Paul Farmer to study public health and inequities too. Structural violence means the multiple ways in which economic and political systems harm particular groups of people in communities. Why is this structural? Because they are institutionalized. Their policies, their structure, their ways of living and interacting with others are part of institutions. What are some of the examples? The criminalization of homosexuality, the denial of HIV, for example, here in San Francisco, our housing policies, the residential segregation of neighborhood, the exclusion of people of color from schools, the searches that we are subject to by randomly by police officers or immigration officers. Those are structural violence phenomena. Intricately connected with that is stigma. Stigma is a concept that I started using a couple of decades ago to study the AIDS movement, particularly the involvement of Latino, gay, bisexual, and transgender folks in the AIDS movement. Goffman took this concept from, of course, Greek terminology and philosophy and applied it to social science. And here let me quote how he described it. The Greeks, who were apparently strong on visual aids, originated the term stigma to refer to bodily signs designed to expose something unusual and bad about the moral status of the signifier. The signs were cut or burned into the body and advertised that the bearer was a slave, criminal, or a traitor, a blemished person, ritually polluted, to be avoided, especially in public places. This is a social phenomenon. This is not a psychological phenomenon. This is something we societies create to manage and control populations. This is what we do with people that do not have homes. This is what we do with sex workers. This is what we do with gay men, with transgender folk, with people living with HIV, with people living with mental health. We call on that difference, quote unquote, and we attach negative values to that, and then we act on those by process of social exclusion. And then we have health equity. And by health equity, I mean not a health disparity. Let me highlight that important difference. Health disparity only means a difference in risk, vulnerability, illness, or prevalence across groups. That's it. It's just a difference. Health inequity means that those differences are attributed to social exclusion process, to processes of power. And my argument in the research that I do is that the basis of health inequity is precisely structural violence and stigma. So if we really want to move forward and achieve health equity, we need to look at these processes more than the social determinants of health. We need to look at those processes of stigmatization embedded in the structural violence of our societies. Right, now into detail. So what are we actually studying with older gay men? Let me walk you through those. First, we have the health that we're addressing. Empirically, we're collecting data on self-rated health, functional health, cognitive function, depression, sexual risk behavior, substance abuse, and adherence to antiretroviral therapies. Remember that we're comparing these health outcomes across racialized groups and across people living with HIV. And the idea is that these health outcomes are shaped by proximal factors and distal factors. So the distal factors that we're looking at is layer stigma. By layer stigma, we mean the unique or combined effects of stigmatization based on homosexual behavior or gay identity, racism, HIV and AIDS, and age. How does stigma affect those health outcomes? There are two broader ways to simplify the process. One is by basic social exclusion process. We don't allow people of color in these particular places. We don't provide health services. We don't provide mental health services and so forth and so on. So it's clear social exclusion. The other one is how is that experience gets under our skin, not only affecting the stress process of our immune system and our physiological processes, but in our self-concept. The idea is that when I was growing up and I was being told that I was feminine, that I have an accent, that I have a skin color that is not good, those ideas, when they become part of my self-concept, they put me at risk of mental health, substance abuse, and probably sexual-based behavior. That's how stigma, using the words of our colleague David Williams, gets under our skin. So we're studying both the experience, the internalized process across the life course, as I showed you before, in different spheres of life. So we're looking at experiences in the workplaces, in intimate connections, in the neighborhood, and in the larger society. Then we have structural violence. And I love this idea of structural violence. Let me sort of tell this story. The reason we have this funding right now is because the NIH put an RFA a couple of years ago looking at structural discrimination, and we're submitting this proposal under that one. I can tell you in another setting, perhaps, how many hours I spent with NIH officers trying to convince them that what we were trying to do in understanding structural discrimination, structural violence, and discrimination with other gay men was structural violence, was structural discrimination. They couldn't realize how LGBTQ climate, for example, was discrimination, how it was structural. So I spent many hours, and hopefully the reviewers liked our work, and then we found a wonderful officer that was supported and believed in our research and how we landed here. So how we're measuring structural violence, we're operationalizing at a neighborhood level. This is so important because, as we know, our zip code defines a lot of our health outcomes, but because our agenda, or at least my agenda, is that we must promote aging in place. And if we want to move towards that, we need to understand where older folks are living. So we are addressing structural violence in two ways. One is racial residential segregation. Many of you are familiar with this idea, in which we look at the neighborhood composition in terms of race, ethnicity, and poverty levels. The idea being that if I live in a ethnically homogeneous group, it will buffer me, or provide a buffer from the larger discrimination and stigma that I face in the larger society, let's say in my workplace, in the bus, in the transportation, in the media. But also means that if I live in a mostly African American or Latinx community, most likely I'm poor. I don't have access to resources such as park, grocery stores, clinics, and so forth and so on. And then the LGBTQ climate is a relatively new measure that we're using. And this is very exciting because now we're using the new census data that allow us to assess the density not only of same-sex couples, but actual LGBTQ folks. So that's one measure. The other measure is we are collecting geographic data to see the closeness or the proximity of LGBTQ-related resources, all the way from religious services, bookstores, libraries, coffee shops, clinics, hospitals, and so forth and so on, that are connected with LGBTQ communities. So this is the two ways in which we're looking at how this neighborhood context can serve as both, either buffering or putting further stress in older folks. The third is resources. And this is in the tradition of the social support process, a stress and social support model that have been used in sociology for many years. What does resources mean is what we as individuals and groups have in our daily lives to face the challenges that daily lives confront us with. So one, we have our inner strength. Inner strength is, if you will, like in traditional Chinese philosophies, is like the candle that we were born with that provides the light, the energy for us to live. That's our inner strength. Then we have social support. Do we have someone that we can call when we face a problem, when we face a need, someone that can help us? And then we have community involvement. Community involvement, I first started investigating and doing research on it with the book that I titled Compañeros with Latino Gay Men, in which we found that the participation, the civic involvement of individuals in organizations, particularly related to LGBTQ issues and HIV and issues, serve as a buffering of the stigma that they were experiencing. That involvement allowed them not only to find peers in social support, but to reframe the stigma that they were facing on the basis of racism and homosexuality and HIV. How? Because those organizations provides a framework for us to understand our place in the world. We're not only changing society as we do in our social movements, we are reframing the way we look at ourselves in society. No longer the stigma is something inherent in me, in my accent, in my gayness, in the way I look, in the way I dress. No, it's something that comes farther beyond me. It's something that the other, the religion, the government, the political parties created an idea that they're trying to put on me. When that reframing of stigma happens, then we develop further inner strength and we become a resource to really being able to not only change society, but buffer those negative effects of stigmatization. And then we have our biomarkers. This is the first time in my career that I'm actually collecting biomarkers. So I'm not an expert, I'm learning still on this. And the idea is, basically the idea of the stress process is that the stress that we experience in our daily lives puts demands in our body, in our immune system, in our physiology. And over time, they were overused and depleted. So we're looking at two ways: inflammation, that put us at a higher risk for certain conditions, and then we have an actual cellular aging. These will get us closer to the question of accelerated versus extraordinary aging, and also would allow clinicians or the practice at the clinical level to better assess the health of older folks. So this is all about the research that I wanted to share with you at this point. But what I want to talk about right now is where I have been, going back to my positionality as a researcher, as a brown, and as a gay person. Through my career, I have been in public health. I studied public health, and I've been working with schools and programs of public health for the last couple of decades. In my career, I realized early that I was pretty much by myself. Frequently, I was just the only person of color in an NIH review panel, in a search committee for faculty, or in a committee for the university committee for promotion and tenure. When I started my careers, my peers, my social support, my intellectual support was not in my institution. I found that support here at UCSF, what is called right now the Division of Prevention Science, in the Visiting Professors Program. What we found there, many of us, is not only leaders and mentors like our dear Rafael Diaz and Barbara Marin, who supported and created this program, but they brought together people, scholars of color, who wanted to do research like this one. We found a space among ourselves, not only that we support each other, but that we could talk about racism stigma, structural balance, and how it was affecting our lives. We could bring our personal selves to the table. To these intellectual discussions, we were able to develop research programs that were funded by NIH. In this graph, you see the public health faculty by rank and race and ethnicity. These data were generously provided by the Association of Schools and Programs of Public Health to us. What I want you to see and focus on the three first categories: the professor, associate professor, and assistant professor. I think the picture is pretty clear. As you move from assistant to professor, the number of white faculty increases, and the number of faculty of color, already very small, reduces. You don't see American Indian, Alaska Native, Native Hawaiian, or Pacific Islander faculty. Of course, we have a big problem here. We have a problem of recruitment, retention, and promotion of faculty of color, particularly Latinx, Asian American, American Indian, Native Hawaiian, Pacific Islander. So when I realized this, I called on my colleagues a few years ago around the country, and we created what we call Latinx Public Health Faculty Collective. We had two purposes. We do have two purposes. So one is, of course, to support each other, because in our institutions, we don't have enough of us. So we have to reach out to Puerto Rico, to New York, to wherever we are, to come together to support and share resources. The second is to advocate. We're trying to change the representation of faculty of color in the ranks and leadership positions of schools and programs on public health. We publish our call for action. It has 8 points. I invite all of you who are listening to this to please visit our website and add your name and your institution and your signature to our call for action. Last time I checked, we were about 190 signatures, and we are lobbying foundations, accrediting body, organizations to be inclusive. We're trying to hold them accountable to what health equity is calling us to do right now, to be inclusive. Our students are more and more students of color. We need faculty of colors. The health inequities are particularly based on systems of racialization and exclusion. We bring those folks into the table. Along those lines, in my professional career, I have been editor-in-chief of a couple of journals. Currently, I'm the editor-in-chief of Health Education and Behavior. This journal is owned by the Society for Public Health Education, a society that I've been member since I was a master's student. What I have found here as an editor is a very similar pattern, and we all know this. The publication process in our research and science has tremendous bias towards scholars of color and women. And this is a very difficult phenomenon to tackle because of the peer review process, in which the authors, the reviewers, are anonymous. So here I highlighted a few of the activities that we're doing to try to address this bias and change the racism and sexism that we see in the publication process. First, I have created an editorial board in which at least 50% of them are scholars of color. Right now, 68% of them are women. We have created special issues. One of them is scholars of color. Only scholars of color were first authors or senior authors. And now we'll be publishing later this summer and this year a special issue focused on students only as first authors. I also have a board of trustees, and I'm accountable to that. So every year in April and March, I have to report to the board of trustees of the society my work as an editor. And they have a metrics in which they see who is in my editorial board, whose papers are being published, and how I'm bringing more and more anti-racist practice into the publication process. And last, 2 years ago, we joined the Coalition for Diversity and Inclusion in Scholarly Communications. This is an international group of publishers in which we are trying with a big collective. We're trying to understand how we can change the process so that we can collect data and make decisions based on data that help us address this bias towards authors of color and women. Well, I started with a promise of bringing a tapestry of health equity and bringing three threads together: the structural violence and the stigma, the positionality, and the anti-racism practice. I want to leave you with two concepts related to this tapestry of health equity: interdependence and positionality. By interdependence, I mean my connection as a scholar with the subject of research, with the people that I work with, the research that I address. They influence me, they inform who I am as a scholar, as a person, and I bring my own perspective to them, and I shape the way I look at their quote unquote problems or their solutions. We cannot deny that interdependence. We are intricately connected. The second is the positionality. Who am I not only as a person? Yeah, it's important, but my position in terms of social status, right? What is my class, my university, my institution, who's funding me? That, I hope my presentation has informed, shapes how I look at health, what kind of research that I do, and how I work with those I research. So the lesson for me is, if we really want to move towards health equity, we need to take into account interdependence and positionality in our research. We need to look at our institutions and create institutional change that acknowledge that interdependence and that positionality. That means that we need to bring scholars of color and women onto the table. What we do as a researchers on the one side, on the one hand, and who we are not separate things. They are intricately connected. And that's why it's so important to create institutional spaces that do not exclude, but include and bring different lenses and different perspectives to address health equity. Thank you. I'm ready for your questions.
Fabulous, Jesus. Thank you. Very instructive and inspiring, and raises a lot of questions. If folks have questions, please put them in the Q&A. You've been very personal talking about your own experience, so I'm going to push you a little bit on that. First of all, it's a very hard question. You were at UCSF 20 years ago. You've come back. What does it feel like in terms of the things you've been talking about, and in terms of the work in DEI and the environment? And do you feel like we have an impression of where we are, but it's all very internalized, and you've had the opportunity to look from different perspectives?
It feels very exciting personally, because it's something very deep in my my career. So in that way, it's a very exciting. It's something, like when you're not talking a couple of years ago, I want to do. And not only I want to do, I want to be supported in doing that, right? And I want to have access to resources to do that. So I find right now in a position in which I hope can affect some change. I find a group of peers that are interested in doing this, and I find an institution that I believe in my own hiring has made a commitment to do this. And this is not unique to UCSF, right? This is pervasive in our institutions. So to the extent that we can contribute towards that, I'm super excited, and part of presenting this and choosing this topic is that.
Okay. And thank you. Another maybe personal questions. Your career has been not unique exactly, but an obvious effort at balancing the scientist, the professor, which sort of implies some level of neutrality. I'm looking at, quote, the science, whatever that is, right? With a mindset of an activist, of someone who's really trying to change the system. And I know we've got a lot of faculty and trainees and staff who kind of are in that space and find it sometimes difficult to navigate. Like, how do I decide how activist I can and should be in the context of what one thinks of as a professor and a leader? So how have you managed to pull off that balance? And do you have any advice for people that are trying to live in that professional space?
Wow, it's pretty hard, right? I was asked a couple of nights ago by part of my team, a research team, why do I do what I do? And I said, well, I have no answer. This is me, right? There's no way to deny me. And I don't know otherwise, right? I don't know other ways of being by being this. I think what has helped me and to get to this point in my career as a senior scholar, if you will, is the support. You know, I really had important mentors at the University of Michigan and here the visiting professors that supported me, that didn't quiet me, didn't tell me, don't do that, don't do that. One of my dear friends and mentors, he did tell me when I was going to the job market, you should cut your hair, Jesus. That was as much as they said, you're not going to be hired for that. But from the very moment, you know, when I was doing job interviews, when I was writing my proposals, it was me. And I was so fortunate to find the support of people that were opening the ways that they said, yes, you can do this, look at this, look at this. This is how you can sell, you know, what you're interested in doing. I can tell you, for example, when I was a doctoral student in the University of Michigan, my dissertation was the first fully ethnographic work as a dissertation. In my department, I had education and behavior. It was always quantitative research. And at that time, my mentor then was also making important changes in NIH, in which NIH finally started open to qualitative research methods. And the same thing with the visiting professors. I found a group of people that allow me to grow intellectually and feel confident that I can combine, you know, my thinking with the quote unquote the science and sort of influencing each other. And of course, of course, I have a family that are always sort of behind me and say, yeah, you can do this, you cannot do this. Mm-hmm. We all face challenges, right? Because academic work is still very difficult, particularly for people that are in the margins, because it takes a lot of work to come to the table versus all other folks. And so I have the fortune of having that support. So I think that's sort of the advice and what I try to bring to this table and to UCSF and other settings is that support, that encouragement, and that dialogue that people can bring their intellectual passions and their personal selves to the table as we move forward with science.
Great. I have to note that your hair was much longer while you were interviewing for this job, and it's gotten shorter since you got here. So
I was more confident.
What to make of it? That's great. Speaking of people who've balanced activism with rigorous science, Dean Schillinger has a question. Dean asks, given how larger policies, structures, and institutions underlie structural violence and the strength of the effects of structural violence on health outcomes, how do you situate behavioral and or individual level interventions in the context of these larger forces that play out above the level of the individual?
Well, I mean, that's sort of the big problem that we face, right? NIH has been, traditionally funded as a very medically oriented, right? And very little by little, making some structural changes, moving more toward the structural level. We have to remember that public health, this is what I do, public health and its origins in England and France was structural. Well, it was about the quality of the water, the quality of the housing, the quality of education. And so here, when it came to the United States, the particular social political position, and I can go on and talking about the history of that, it became dominated by very behavioral orientation, right? So we need to start moving, pushing particularly those institutions to those rather phenomena. And it comes down to the pipeline, right? So we need to start training our doctoral students and master students away from the individually behavioral psychosocial process and rather bringing economics, politics, anthropology together to influence that, right? So that we can have a better balance. I think the idea right now is that much of the funding and the interventions are thought about individual level behavior. As an example, right now, CDC has an RFA for mistrust, medical mistrust. right? And I have colleagues and citizens are talking to them. It's like, okay, are you open to talk to institutions, not to individuals? Let's not put the responsibility yet again on the victim. Let's talk about where the mistrust comes from. What are the sources? And are you willing to work with us in talking with organizations, clinicians, health departments? Because that's where the change needs to happen, not at the individual level.
One thing that came up for me as I listened to your talk, this notion of intersectionality, and it sort of came up as your diagram of the neighborhoods and the importance of building communities. And I, sort of naively, maybe not think enough about, okay, I can imagine a gay man who's aging, who feels like that's the community I want. And I can also imagine a Latino man feeling that's the community I want. But the world sort of morphs these people together in all sorts of, wonderful Venn diagrams. So how do you think about that when what your community, you may have multiple communities and you may live in many of them, and yet you're trying to reconcile all that as you try to construct the community, the attitudes, the atmosphere, the culture around you?
You mean, how do we prioritize, or how do we?
Either I guess I would think, for example, take your neighborhood work. If you were looking just at gay white men, you might come up with one thing. If you were looking at Black gay men, you may come up with a different thing. And you're trying to figure out sort of what actually does constitute the community here when people have multiple identities.
No, you're absolutely right. It's very complex, right? And that's what we're trying to do research, in what's sort of particularly because I think I want to believe that in public health, our agenda is to build communities where people can age, right? That instead of institutionalizing them and spending all the resources there, we create these environments. So on the one hand, how can we, it's very complicated because how can we create the larger environment change so that it doesn't matter where you live? Right? Wherever you live, you have access to parks, to stores, to transportation, to talking English or Chinese or Mandarin or whatever you want to do, or celebrate whatever you want to. So that is a broader, larger social change. The other piece that also what I'm focusing right now is where people are there in the community that are there, and highlight of how they have come to be. Because this is not an accident, right? One of the issues that I was arguing in a collegial way with NIH officers is, look, gay people do not choose where to live. Our choices are very limited, right? We are forced and compelled to create these communities, right? Because we could not change the larger environment. And so how can we understand how that community indeed is helping or not helping folks, right? So that's one perspective. But understanding that we are not monolithic, right? Within the queer LGBTQ community, there is tremendous sexism. There is tremendous racism, right? So how can we change that? So in my ideal world, if you will, we have an aging community that is inclusive right now, but of all racialized groups and other queer folks. But we don't have them right now. When I was doing the book a few years ago, what we were learning was that in the words of a woman, a lesbian woman, she says, we're going back to these neighborhoods and institutions where we ran away from originally. We're finding the same homophobes. So you feel, like yourself, or that you're walking to a particular place in your life and the rest of the world is walking with you. And then when you get to the stop, no, you were walking there only with 3 folks. The rest of the folks are 50, 60 years behind, right? So that's sort of the complexity and difficulty that we face. I don't have a straight answer to that. And that's why I wanted to collect this data.
Great. Well, the complexity is striking, but it's also clear that if you don't attack these kinds of problems, thinking about the complexity and the nuance, you're not going to get it right. And so we're thrilled that you're doing that, and we're thrilled that you're here to help us do it, and really enjoyed the talk very much. Jesus, thank you so much. Really appreciate it.